Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to our June 2018 NDUS Presents webinar. The NDUS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, NDUS Co-I. Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are all part of the NDUS Coordinating Center team. For those who are interested, you can find detailed information about NDUS, recordings of prior webinars, and invitations to future webinars on our website at www.ndus.org, www.ndews.org. You will also find instructions for how to join our NDUS network and participate in ongoing discussions about a variety of topics, including epidemiology, toxicology, and drug policy, with more than 1,000 experts and concerned citizens from across the United States and many other countries. So if you haven't joined us, I hope you will do so. We developed the NDUS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This one, we are highlighting the new National Hospital Care Survey designed by CDC to identify opioid-related hospital visits. This morning, we are very fortunate to be joined by two experts from the National Center for Health Statistics, Dr. Carol DeFrances, Chief of the Ambulatory and Hospital Care Statistics Branch, and Margaret Noonan, Team Lead for the Hospital Care Team, who will co-present today. The webinar will be approximately 60 minutes long, but it may go a little longer depending on questions. We encourage you to submit your questions during and after the presentations. Please post your questions in the Q&A box, as we can't respond to raised hands, so please submit them in writing. We will hold a brief Q&A session after both presenters have spoken. Our presenters, Barbara, Marwa, and I, will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar and a copy of the presenter slides will be made available on our website, which again is www.ndus.org. Thank you, and we hope you enjoy this webinar. So, Dr. DeFrances, I'll turn it over to you now.
Thank you, Erin. Good afternoon. As Erin said, I am Carol DeFrances, and I oversee all the ambulatory and hospital surveys at CDC's National Center for Health Statistics. Margaret Noonan and I are delighted to be with you today to talk about the National Hospital Care Survey. We would like to thank the NDUS staff for this opportunity. Let me start with an overview of the presentation. I will start out with talking about the goals and objectives of the survey, and then talk about the methodology and data collection. Then I will turn it over to Margaret, and she will talk about the uniqueness of the hospital care survey, talk about identifying substance-involved emergency department visits using the data, give you some preliminary findings, and then talk about our methods or ways that we're improving the identification of substance-involved ED visits using EHR data, and then about our efforts for moving forward. So let me begin with the goals and objectives of the survey. The goal of the National Hospital Care Survey is to provide reliable and timely healthcare data for hospital-based settings. The objectives: move toward electronic data collection, particular electronic health record data collection over time. Continue to make available health statistics previously provided by NCHS, and then link episodes of care across hospital units. So if someone comes in through the emergency department, is admitted as an inpatient, and seeks outpatient care all at a sampled hospital, we would be able to trace that care. We also want to link to the National Death Index, which is housed at NCHS, and link to Medicare data. Now, let me briefly talk about the methodology and data collection. The 2018 sample consists of 598 non-institutional, non-federal hospitals with 6 or more staffed inpatient beds. The sample is designed to produce national and regional estimates of healthcare utilization in the inpatient, emergency department, and outpatient department settings. Please note, military and Department of Veterans Affairs hospitals are not included. Let me start out in terms of hospital recruitment. Participation in the hospital care survey is voluntary. In addition, NCHS also keeps the names of sampled hospitals due to privacy concerns confidential, so that complicates our efforts to get others to speak about the survey on our behalf. Hospital recruitment has been very challenging. In 2016, only about 20% of the sampled hospitals were able to give us data. There's some reasons for this. Hospitals have competing demands. They must comply with many mandatory reporting requirements. They don't often have the time for voluntary efforts. Some hospitals also lack the resources to participate. Setting up the initial transmission for the data can also be time-consuming. Making the business case for participation has been a challenge. Why should hospitals participate in the survey? We offer a number of incentives, such as meaningful use credit through the CMS EHR incentive program and reports back to the hospital, but in many instances, this has not been enough. Moving on to data coverage and sources, we ask that hospitals send us all inpatient discharges, ED, and outpatient visits for a 12-month period, which is January through December. Our data sources, we started out collecting initially UB04, administrative claims data. This is billing information. In 2015, we moved on to claims plus some meds and labs from Vizient member hospitals. And also in 2015, we started to collect EHR data. Why did we transition to EHR data? The answer is that EHR data present a tremendous potential for the National Hospital Care Survey. We believe that the burden on the provider will be less with electronic submission of data from the EHR than physically going on site at the hospital to do medical record abstraction to collect clinical information. EHR data will be definitely more clinically detailed than administrative claims data. We won't be limited to 25 diagnoses and 25 procedures as we currently are now with the claims data. We can get all diagnoses and all procedures. There also is the potential for more data in terms of volume. We're not limited to just collecting a sample of visits. We can collect a year's worth of visits, as I previously mentioned. We can collect more types of data than we currently collect, such as allergies to medication, problem lists, family history, social history, alcohol, substance, and tobacco use. And finally, we think EHR data will allow better identification of ED substance-involved visits through lab and medication data. In terms of the elements, we collect personally identifiable information, or PII, such as patient name, address, and social security number. We use this information for linkage purposes and collect this both in the claims and EHR data. In terms of demographic information, we collect this in the claims and EHR. Information such as age and sex are collected. We also collect diagnoses and procedures in both the claims and EHR, but as you can see, there also is much more clinical information that's available through the EHR. Now I'd like to turn the remaining part of the presentation over to Margaret Noonan. Margaret is the team leader for the Hospital Care Survey, which oversees the day-to-day operations of the National Hospital Care Survey.
Good afternoon. My name is Margaret Noonan. I am the team lead for the National Hospital Care Survey. And now that Carol has given you an overview of the survey, I'm going to delve deeper into the substance of the survey. I'm going to start with what distinguishes the Hospital Care Survey from its predecessors and from other hospital care surveys. The first strength of the NHCS, or the Hospital Care Survey, is the visit volume. So as you can see on this table, annually we receive tens of millions of records from hospitals that participate in the Hospital Care Survey. You can also see that while our participation numbers of hospitals is lower than desirable, in the early years it was less than 100. The number of hospitals that have participated every year has increased. So currently, as of data year 2016, we have approximately 140 hospitals participating. This is an increase from the earlier years where I said it was just below 100. The second advantage of the Hospital Care Survey is that we do collect personally identifiable information, or PII. This also distinguishes it from its predecessors in that what makes PII such a great data source for us is that it obviously allows us to report on the characteristics of persons who are seeking hospital-based care. It also allows us to look at the files at both an encounter level and again at a patient level. And the patient level distinction allows us to link the data to external sources, and it also allows us to track patients within settings, and it also allows us to track patients across time. So the biggest advantage of being able to link to external sources is currently we have undertaken some work to link the hospital care survey to the National Death Index, and we will have undertaken work to link the hospital care survey to Medicare data sets, and this allows us to give a comprehensive view of patient-based hospital care in the United States. So the NHCS, in conjunction with the volume of data and the inclusion of PII, allows us to really take a deep dive on the study of hospitalizations. And this allows us to look at the bigger picture and the more common conditions such as heart disease, cancer, other chronic conditions such as asthma, pneumonia, COPD, and the hospital care team has undertaken work to look at conditions specifically such as asthma, pneumonia, and strokes. And those, the findings from those studies will be out hopefully sometime this year. And we've also been able to look at less common conditions such as traumatic brain injury, and the paper on traumatic brain injury is currently available. And it also, for this group, what's important is it allows us to look at injuries, both intentional and accidental. And of course, this is critical when looking at drug-involved hospital care visits, specifically when we're looking at opioids. And looking at this slide, as you can see at the bottom, for data year 2014, using the hospital care survey, we estimated about 1% of persons seeking ED care were there for an opioid-involved visit. So keep that in mind. I'm going to come back and revisit that in the next few slides, but I want to talk a little bit more about some other aspects of the hospital care survey. So this brings us to identifying substance-involved ED visits, and I wanted to give you a little bit of background as to how we ended up using the NHCS, or the hospital care survey, to identify substance-involved ED visits. So in 2011, the Substance Abuse Mental Health Services Administration, better known as SAMHSA, discontinued the Drug Abuse Warning Network, was better known as DAWN. This was due to increasing costs and diminishing returns. It was a data system that had clinical abstractors visiting hospitals and manually reviewing hospital records to identify substance-involved hospital visits. This was a clinically rich data set, but it was burdensome, it was expensive, and SAMHSA had to make the difficult decision to discontinue the survey. Once they discontinued the survey, they approached NCHS to use the hospital care survey as a potential replacement for DAWN. And so that work was undertaken by the hospital care team in conjunction with our partners at SAMHSA, and we started to look at the data to see if we could recreate a DAWN-centric system. We quickly realized that trying to recreate DAWN in its totality from the hospital care survey was not going to be feasible for a few reasons. The major reason is that the hospital care survey is a claims-based system, and the claims-based system, although it does have some great uses, it primarily is aimed for billing purposes. So there is limits on what you can do. And of course, the biggest setback is that it doesn't have the clinical notes like you would see in a medical record. And of course, a medical record is focused on the clinical care of the patient at hand. So it's going to have information in it that would not necessarily appear in the billing data. And then again, the nature of the billing data had some quirks, and probably the two biggest problems for us was one, that it's limited in the number of diagnoses that it can record. It caps at 25, and of course not all hospitals bill up to 25. There may be less information than that. And then another issue was that it was what we would call a carryover diagnosis. So you may have a patient presenting for hospital care, and they had previously sought care for a substance-involved issue, but the current visit had nothing to do with that previous substance-related issue. And so it would result in what is known as obviously a false positive. And then the other issue, and this is a more minor issue, was the abstractors with the Dawn. So Dawn went in, they sent these trained clinical abstractors, but part of the problem was that you had to rely on, there was the expertise of the abstractor, and there was some level of human error. Obviously, this SAMHSA took steps to address this and to improve the training and to improve the quality and the consistency of the abstractors' decisions, but those were some issues that I wanted to make you aware of. So after realizing that using the hospital care survey to recreate Dawn whole cloth was not really going to be feasible, we moved towards a system where we would be creating a algorithm that would allow us to look at the hospital care data and come up with an estimate of substance-related hospital visits. So in conjunction with SAMHSA and also with our Division of Vital Statistics at NCHS, we were able to look at some clinical codes that would help us identify substance-involved visits. And in conjunction with this information, SAMHSA provided us with a list of 10 priority substances, which are on the screen now. And as you can see, they're actually in alphabetical order. It's not hierarchical. I just wanted to bring that to your attention. So the current algorithm is applied to the claims data, and it's what is known, what we refer to as a general algorithm, which broadly searches for the International Classification of Disease Codes, better known as the ICD system. There's versions 9 and there's versions 10. For the years that the hospital care survey have been in the field, it bridges between 9 and 10. In data year 2015, hospitals moved from the 9 system to the 10 system. So we have a mix of both codes, but for the current algorithm, it's based on the 9 system. So the algorithm basically searched these diagnosis codes looking for substance-involved hospital visits. Obviously, the algorithm has been helpful, but there are some limitations to the algorithm, which are outlined on this slide. I'm going to talk a little bit more about. The first is that it's based on not only the ICD system, it's also based on external codes. And the biggest drawback to this is that while it may identify the family of drugs, so for instance, opioids, it cannot drill down to the specific drug. So for instance, if you have somebody, they'd be recorded as an opioid-involved visit, but they may not necessarily be able to say that they were there because of a heroin overdose or because of exposure to fentanyl or because that they had been misusing opioid prescribed medications. The algorithm, as I sort of alluded to earlier, is not able to really accurately enumerate false positives or false negatives, which obviously is a big issue for us. We're more concerned about the false negatives than the false positives. Because we believe that there may be a bigger issue than the false positives. And this would require a validation study. We have taken steps to undertake a validation study, but it's still in the works and it's in the very early stages at this time. And the algorithm currently is only using claims data to date, which again, as I mentioned earlier, is used for billing purposes, not for research. And then this is sort of an important point to make for the claims data, and particularly for people that are interested in opioid-involved hospital visits, and that's that it excludes charity cases and self-pay visits, which is believed to be somewhat common with opioid-involved persons. And it can be, again, as I said earlier, it can be hard to distinguish between present opioid problems and past opioid problems or present and past substance problems, because you may have come in, you may say to the provider that you'd had some sort of drug or alcohol issue in the past, trying to better inform your care, and it may end up on the record or maybe a carryover because you had previously sought care in the hospital for that same issue. And this is sort of a more minor point. It can't always distinguish between the setting. And this is an issue a lot of times as the patient moves between settings of care. So it isn't always obvious if the person is currently in an inpatient setting or the ED setting, or if they went directly from the ED to the inpatient. And that's just a little bit of noise in the data. So the rest of the presentation, or the bulk of the presentation, I shouldn't say the rest of it, is going to be presenting some preliminary findings, which is the result of the current general substance-involved algorithm, and it's using the 2014 hospital care data to come up with these findings. I just wanted to give you a few caveats before we delve into this. So the first is that these are focused on opioid-involved visits, and it's in the emergency department setting. And the reason why we focused on the ED setting rather than other settings is because we felt that it would be the most common setting that persons would seek care for an opioid-involved issue. The second issue is that the findings that we're about to present are unweighted data and they're not nationally representative. So please keep that in mind as you see these findings. So this is the first finding, and the first finding is just sort of a bit of context. I should also mention that the first two slides, there are a total of 4 slides with findings on them, are at the encounter level. So this is just a broad view of 4 hospital encounters. About 1% of them are opioid-involved visits, and it represents about 39,000 visits out of a total of about 4.5 million visits in 2014. And this again is at the encounter level, and this is looking at male versus female. And as you can see, there were more males than females seeking ED care for an opioid-related issue in 2014. And so the next 2 slides I think are really interesting because this is another demonstration of the hospital care survey, in that it allows us to not only look at the encounter level, but then it allows us to look at the same issue again at the patient level. And because we can look at the patient level, because of the inclusion of PII, is that we can follow people across settings. And we can also follow them across time, meaning that we can look at people that are coming back for multiple visits. And as you can see here, for opioid-involved visits, the majority of people that are seeking care for this issue do not return to the ED, but about 20% of them do. So this is just something that is another demonstration of the data and how it can be used. Just another reminder, it's not nationally representative. And this is the final slide having to do with findings. And this is probably my favorite slide because I used to work on a mortality project before I came here, so I'm always interested in mortality findings. And this is sort of allows us to look at it from 2 different angles. The first is that died at the hospital, that is before it was linked to the NDI. And what that shows is that about 1% of patients that are seeking hospital care for an opioid-related issue died in the hospital. It should be noted that it is actually fairly uncommon, regardless of the condition that the person's being treated for a person to die at the hospital. But what is neat about the PII inclusion in the hospital care survey is that it allows us to link to the National Death Index. And the National Death Index is a full enumeration of death certificates filed in the United States. And so we can track these people after they've been released to see what their mortality outcomes are. And as you can see, about 1% die within 30 days, about 1.5% die days 31 to 90, and that increases to about 6% die after 90 days. Now, one caveat for this is that this does not delve into cause of death, but that is just, we are able to do it. We just did not do this for this presentation, but that is something that we will probably delve into in when it comes time to publish papers on the findings for the opioid project. So now that we've talked about the general algorithm, I wanted to talk about our efforts to improve the existing algorithm and really include the EHR data and the power of the EHR data and how it improves on what we currently have and additional avenues to explore. So as Carol mentioned earlier, starting in 2015, NCHS started collecting EHR records through the hospital care survey. The EHR data includes additional elements of interest for us, primarily the clinical notes. And the clinical notes sort of calls back to what the DAWN system was, where they had the hospital record and they're able to incorporate that information to make a decision as to whether or not it was a substance-involved case. And we are planning on doing the same with the clinical notes for the hospitals that are submitting them through the EHR. And it also includes labs and medications. And the labs and medication data can really be useful because it can help us determine the difference between a false positive and a false negative. So you may have some information in the clinical notes that may be indicative that it might have been substance involved, but the inclusion of the lab and medications, if they come back negative for all sorts of tox screens, then you probably can say that it actually is not a substance involved ED visit. And also what's great about this information is that it allows us to identify information that may not be captured elsewhere on the record. So again, in the notes may have something where the person comes in for something that is seemingly drug unrelated, and by assessing the notes, it may become clearer that there actually was some sort of substance involved in the hospital visit, and that it should be included as a drug case. And so we also, in addition to improving the current drug algorithm, we have been awarded some money through the Patient-Centered Outcome Research Trust Fund, which we refer to internally as PCORI, through an opioid project. And what the strength of this project is that it is sort of the culmination in all the work that we've done previously. It's the current algorithm, the improved algorithm, and then incorporating external data sources, including the National Drug Index, which we have been linked to, and then also using the National Vital Statistics Restricted Use Mortality File, which is a great advantage to us because it involves specific drugs involved in a death. And why this is important is because it allows us to improve our drug algorithm by incorporating the clinical notes. And I didn't mention it before, but part of the way that we're going to improve the clinical notes or incorporate the clinical notes is through natural language processing, which allows us to drill down into the data and look for certain search terms that are indicative of a substance abuse involved case. And so the NVS restricted mortality file will have some drug mentions, or what is known as a drug mention index, and we'll be able to use their information in conjunction with our information and come up with what we are referring to as a super algorithm. And the super algorithm will allow us to go through the data and really come up with a algorithm that is accurately identifying these cases and hopefully addressing the false positive and false negative issue. So the outcomes for this project is that we will have a web-based portal to report the clinical information back to responding hospitals or hospitals that are in the sample and are submitting data. And it will allow us to disseminate new data files, methods, findings, and other output for the project that will better inform the general public and, of course, the research community at large. And so I wanted to take this opportunity to highlight the data that is currently available through our research data center at NCHS. And this is the link to the RDC, what we refer to as the research data center. Currently, we have the 2013, 2014 data files at the RDC, and the 2015 data file went live a few days ago. So that is slightly outdated, was saying that it's available in June, although I guess it's technically correct. So in the other data file that might be of great interest to this group is the linked 2014 and hospital care survey to the National Death Index. We also we currently are undertaking work right now to link the 2016 hospital care survey to the National Death Index, but that linked file probably won't be available for quite some time. It's really too early to give an estimated time as to when it will be available because it's not even available to us. So I wanted to close out with our next steps in moving forward. We obviously will continue to recruit hospitals. We are pleased that we have 140 hospitals for 2016, but our goal is to recruit at least 300 hospitals so we can start putting out national estimates for hospital-based care in the United States. Although the talk did talk quite a bit about obviously substance abuse and opioid-involved hospital visits, we want to be able to put out, all sorts of hospital-based care and better inform all the reasons why persons go and seek hospital care in the United States, regardless of setting. We will continue to collect claims and EHR data for the 2018 data collection. We will be focusing on the EHR data because of the potential for the EHR data and the clinical richness of it. So we really want to focus on getting hospitals to submit that data over the claims data. We will continue to enhance the algorithms, and we are planning on a validation study for the algorithms. So in closing, I just wanted to thank you for your time and give you my contact information. If you have any questions about the hospital care survey, you can contact me at the information below. And if you are one of the NDU Sentinel sites, and I strongly urge you to, if you have the opportunity, to get the word out about the hospital care survey to hospitals in your area. And if they are in the sample, strongly urge them to participate. Thank you.
Thank you so much, Dr. DeFrances and Ms. Noonan. We really appreciate all the information that you shared. You really gave us a wealth of valuable information about the NHCS and the data you have collected. And I'm sure that your initial findings and your other information will engender a lot of discussion amongst our viewers and hopefully on the NDUS network as well. We have gotten a few questions in, so I want to move on to our Q&A. And so we have a question from one viewer who wants to know if all of the states are represented in the NHCS at this time.
Unfortunately, no. So the way that the sample was designed, it was to be nationally representative. And so when you design a sample to be nationally representative, you're not able to really produce reliable state estimates because it's just not the way that you selected the samples. I mean, selected the hospitals in the sample, excuse me.
All right, thank you. Just a reminder to everyone participating. I noticed that a couple of you have raised your hand. I need to ask you to please submit your questions in writing through the Q&A box because I can't actually call on you at this time to let you speak up. And so also just as a reminder to everyone, we will make a recording of this webinar and a copy of the slides available on the NDUS website, www.ndus.org. So to come back to our questions, we have one from an attendee who asks, this may be an elementary question, but what's the difference between NHCS and HCUP, which is the UP?
Okay, I don't think that's an elementary question. So HCUP is a requirement for hospitals to report back to CMS, right?
No.
No, sorry.
I will take that. Okay. HCUP was started by AHRQ and it's claims data. They gather information from the states, and again, it's mostly claims data. Hospital care started out with claims data, but we've now moved to EHR data. And the other, I think, point that separates us is that HCUP does not collect PII, and we do, and that allows us to link to the various sources that Margaret showed you. So they've started out kind of similar with the claims data, but because of the PII, we were able to link, and now hospital care has moved on to the collection of electronic health record data.
Okay, thank you. We have another viewer who asks, will either hospital or county identifiers be available in these data?
No, not for the research data sets.
Okay. And somebody else asks if charity cases would be billed to the ACA or to Medicaid. I guess they wanted to know more about how that, if and how that would show up in your data.
Okay.
In the claims data, as Margaret said, sometimes self-pay and charity cases, they're not representative. Some states do submit them. They have a requirement that each encounter in a hospital has to have a claim, but that's sort of a shortcoming of the claims data. We don't have the charity and the self-pay. We're hoping that by collecting the EHR data that we'll be able to pick up those cases.
The next question is from a viewer who wants to know if the algorithm that you've developed will be shared with the public at some point?
That's a good question.
I think the idea is when we actually will start producing reports, we'll have information about how the algorithm was developed. Yes.
All right. Another viewer asks if there is a cost for government agencies to use the RDC.
There are some fees, but again, if someone is interested, please contact Margaret. We can actually work out some arrangement if someone or another agency is interested.
All right, thank you. Our next question is, do you have to get patient-informed consent to take their identified data and link it to other databases?
We have approval from the NCHS Ethics Review Board. We have a waiver of informed consent from patients. We also have the HIPAA waiver. Again, since we're collecting data after the fact, but because of the waivers, we're able to collect the information. Also, the hospitals in their privacy notices also have they have an element that says the data may be used for research purposes. So we're able to do it within the confines of the waiver of informed consent and the HIPAA waiver.
Next, are there any plans to release a de-identified public use file?
I think a long-term goal of ours is to release de-identified public use files, but we have to do quite a bit of work on our end until we get to that point, because we have to satisfy our ethics review board. We have to satisfy some other people to make sure that we're not at risk of identifying people either intentionally or inadvertently, which I think is really the biggest concern, is the inadvertent identification of people, or the potential to inadvertently identify people. So it is a goal of ours, but we've just sort of undertaken those discussions. And I have to be honest, it's probably going to be a little while before we have an answer.
All right. Thanks. We've actually had a lot of questions start rolling in now. So our next one is, would you be able to see whether a patient seen for opioid overdose in the ED then receives MAT, specifically buprenorphine?
That might be a question for one of our toxicologists.
Yeah, we're not sure.
Yeah, sorry.
Okay.
Please email me that question and I can do some legwork on it, but I don't want to give you bad information.
Is any consideration of patient verbal report validity given when formulating the survey?
So do you need, I just wanted some clarification. I hope I'm answering the question correctly. I think what they're asking is, if the patient volunteers that they're there for an opioid-related issue, or if they deny, I think is probably the bigger concern, right? Is that you have a patient that comes in and all indications point to that they are under the influence of something, but they're denying it. I think in those cases, we want to consider several different elements, right? So you consider the diagnoses, you consider the reason for visit, you consider the medications, you consider the labs, and you consider the notes. So I would imagine that they would probably get a tentative match, or like a soft match, rather than, a hard match as a yes. So I think that we do take it under consideration, but I think it will always be some level of an undercount, right? Is if you have somebody that's in there and you can strongly suspect that they're under the influence of something, but if all signs indicate no, if the tox come back clean, then you're going to have to say that there's something else going on.
All right, thank you. Here we have a question from an attendee who asked, is it fairly straightforward to get access to the NHCS data for researchers? How long does it typically take to get access?
What you need to do is submit a proposal through the Research Data Center, and Margaret presented that link. If you go on that website, it doesn't take very long. You have to submit a proposal. It would be reviewed by Margaret and her team, and then if it's, it seems like it would work out, it doesn't take that long, probably a couple of months, but the main thing is you have to submit a proposal to the RDC.
And you can always email me for more information or for some tips on what to do and how to handle it, and we're happy to help.
All right, thank you. Does the NHCS replace the NHAMCS for estimates of hospital outpatient department visits?
Right now, we're running both surveys concurrently, so HAMCS is still in the field. The idea would be over time, if hospital care could recruit enough hospitals and have them participate, that we would phase out HAMCS, but at this point, we're keeping both surveys in the field.
Okay. And next is, why are antidepressants and antipsychotic drugs included in the algorithm since they are marginally addictive?
That I would have to fact check. I'm not 100% sure.
Well, it's separate.
If they are.
Well, it's a separate. They're not. Again, I think the list of 10 drugs that Margaret showed you there were 10. So there are 10 different algorithms. So I think an algorithm was being built.
Okay.
On those separate. So it doesn't mean that it's in the current. Is that we're building separate algorithms for those areas.
Okay. Thank you for that clarification. Has there been any preliminary analysis that would show if the 2014 mortality data correlates with more current data?
No, at this point, no. So unfortunately, we were delayed in getting our 2016 data, and the 2015 data, it has to go through the linkage in a separate stream. So at this point, we only have 2014 linked.
Okay. And we have a couple more questions from people who are interested in knowing a little bit more about what more site-specific information they can get from the data. So for instance, are regions included or states included?
At this point, if we made any estimates, we would have national estimates. The
Okay.
survey is also designed for regional, but at this point, the data that's available is just at the encounter. The survey is not designed at this point for state estimates.
So now we have a question from somebody who asks if hospitals currently participating, when will the 2018 data need to be submitted?
For hospitals that are currently submitting for 2018, we're in the process of contacting them now. We're looking for a full year of data. They have until the end of the year to submit it. Some hospitals do take that option where they do an annual submission, and that's fine. And it usually spills over into the next year of cleaning up the data and verifying some information.
Will the ICD-10 codes be a part of the reports that are provided, for example, to identify various forms of opioids?
As we incorporate the 2015 and 2016 data, yes. But the original, the initial round will not, because it will be based on the 2014 data.
As you recruit additional hospitals to reach your goal of 300, are you expecting some hospitals will not have electronic health records, and how will you address this situation?
Yes, we still accept claims-based data, so not having EHR data is not a reason to not accept data. We will still accept it. We'll work it out with the hospital.
Can opioid-related visits for medical clearance or non-emergent detox be distinguished from visits due to acute opioid overdoses?
I don't think I'm not sure. I think we'd have to look and get back to whoever asked that question.
Another viewer thanks you for doing all of this work and asks if you will be able to link any subset of your data to other kinds of things like the state prescription drug monitoring programs.
At this time, there's no plans to do that, but I think over time, as the data set develops, there may be other opportunities. Right now, we're just concentrating linking on the NDI and to Medicare.
Would the lab tests in the EHR included data allow you to determine what opioid was used by a patient?
It depends, because it depends on how sensitive the test is. So a lot of times what we have been told by our toxicologists and other clinicians is that it will just come back positive for opioids. It may not be able to identify the specific opioid involved. So I'd say we probably get a mix of it.
Here's one more question from someone who asks, has the application of natural language processing to EHR data in any way demonstrated the inaccuracy of the ICD-10?
We've actually just undertaken the natural language processing. We're still putting out solicitations to identify a person who can help us with that work. So at this point, we can't say either way. We don't know. So we'll find out.
Okay, and a couple more questions here. For opioid cases, will the data provided capture if practitioners referred a patient to counseling?
It may in the notes if they indicate it, but I wouldn't, even if we get to nationally representative numbers, I think it will sort of be the issue like with EHR data is that you'll have some, gold nuggets in there, but it wouldn't necessarily be nationally representative, because if it would really be contingent on the fact that all hospitals were EHR, which we know we're not going to be in that position anytime soon. The second would be that they're all consistent in the way that they fill out the notes. And then again, it comes down to what the clinician chooses to write down in the note. So it would be, if anything, it would be an undercount. So I would say no.
Okay. And then one last question here. How long can an individual patient be followed up or tracked in the NHCS data? Is it possible that an individual visited ED in a participating hospital and revisited another ED in a non-participating hospital?
No, yeah, it has to be, that's actually a good question, because that is one of the caveats, is that to track them across settings and through time, they would have to return to a hospital that's also in the sample. So if they were, in a hospital that was not in the sample, we would not know about that.
Okay, thank you. And our last question here actually relates to the reinstated DAWN effort by SAMHSA.
Okay.
So I think we have Elizabeth Crane with us from
Yes.
SAMHSA.
We're delighted to have Elizabeth Crane from SAMHSA, and she will take that question.
So that question is, how will the current efforts of the NCHS intersect with the reinstated DAWN effort coming out of SAMHSA?
Right, thank you for the question. We see the surveys as complementary. DAWN's emphasis has traditionally always been on getting specific drug information. And while, we have funding for DAWN, we're still in the procurement process, so we can't really talk about it now. But yeah, we do see them as complementary data efforts.
Okay, thank you. I think you also had said that you could respond to the question about the inclusion of antidepressants as well.
Yes, the list of the priority substances was based on substances that were being misused, showing up in the emergency department, non-medical use. So it was not restricted to addictive substances. People misuse antidepressants and benzodiazepines and other pharmaceuticals. So that's why they were included.
All right, thank you very much. Okay, thank you everyone for the questions you submitted. I know we didn't quite get to all of them, and so for those of you who still have questions, you can get in touch with us at NDUS, or you can get in touch directly with Ms. Noonan or Dr. DeFrances, and I'm sure we'll be able to get you the information you need. And so for the moment now, I would appreciate it very much if you all would answer a few poll questions for us. So I am launching the poll now, because we would like to get some information from you about what topics you would like to see in the future. And as you can see from the slide I'm showing, we don't have anything planned over the summer. We usually give folks July and August off, because we know everybody likes to try to take vacation and get things done. But we will be back in the fall, and we're working on a number of topics that we're hoping to set up for you then. And so we certainly hope you all have a great summer, and keep us posted on what you would like to know more about. And we in turn will keep you posted whenever we see important or relevant new reports or articles coming out, and especially when we see new information coming out on the survey that you heard about today for the hospitals. And I don't know if Dr. DeFrances or Ms. Noonan, if you have any closing comments you'd like to make, or any final thoughts for our viewers?
Just would like to thank everybody for their time and for participating. We really appreciate the opportunity, and we'd like to also thank everybody at NDUS for being such gracious hosts to us.
Well, thank you very much too. We certainly look forward to continuing to working with you as a part of NDUS. Thanks again, everyone. We really appreciate you joining us today, and we hope you will join us on the NDUS network and in future webinars as well. And again, have a great summer.